Thank you for being here. Thank you for Keystone for the invitation. It's a pleasure to speak for a company, for a product that I view as a game changer. If I achieve my goal here this afternoon, I am going to make you a little bit uncomfortable. But then I hope to offer you some solace and maybe some solutions to these problems, because I think what we're doing as an industry, as clinicians, might not be the best for our patients, and I'll show you why. I hope to share with you some original data, some original research, and leave you with some notions as to what we might be able to do better for ourselves, for our patients. So without further ado, we will talk about the integration of both surgical and prosthodontic protocols for immediate molar implants. You had the pleasure of, and I was here for Team Atlanta's talk this morning. This is SDNY Dental, otherwise affectionately known as Team New York, and these are my partners. And I'm fortunate to be part of a team where we sort of push the envelope and look at things a little differently and criticize and get critical with what we're doing and try to make things better. And it's a wonderful environment in which to practice. Now, when we think about immediate molar implants, what is it that your mind conjures up in terms of a molar? You see, they come in all different shapes and sizes. Not every molar is created equal. And each one of these sites may create a different and unique challenge, if you will, to placing the implant, to creating a restoration that works, that's comfortable. And that's what we're going to explore. So let's see, what are the challenges of immediate molar implants? And they're different from single-rooted anterior implants. It's a different ballgame, and there are different parameters, there are different problems associated with it, and we have to start thinking about it in those terms. So to begin, it's a larger extraction socket, obviously, so stability becomes an issue. In the anterior zone, you normally go 3 or 4 millimeters apical to the socket. Well, posteriorly, we very rarely can do that. We have the sinus, we have the inferior alveolar nerve below the apices of these teeth. So we don't have that opportunity very often. So stability is often an issue. You may have poor bone quality, specifically in posterior maxilla. You may have type 3, type 4 bone. You don't get that in the anterior, so it's, again, a different set of parameters. You may have less bone apical to the site. Like I said, you're dealing with the sinus, you're dealing with the nerve. We need to keep this in mind when we develop a protocol. And that's where this is really about, is developing a protocol for success. So we'll start with the literature review. We'll see what's been out there in the literature and examine what we can glean from that. Then we're going to move on to a classification of molar sites, and that classification system is something that we came up with in order to communicate with one another in hopes of developing protocols for success. And lastly, I hope to leave you with a treatment protocol based on new research that makes sense to you, and hopefully that we take back to our practices and move forward with. So let's start with the literature review. And we start by asking, just like Dr. Bittner, when, why, where, and how do we do these implants? And what we're going to look for in the literature, what I went to the literature to look for was, is there an evidence-based protocol out there? That's important to me. So when you look at the systematic review by Katabi and DePorter, they did a systematic review and they found that there was an overall 98% survival rate of molar implants, immediate molar implants. Well, that's pretty good. And there was no difference between the maxilla and the mandible. And what was interesting to me was that there was double the failure rate when they went out to the wide implants. They didn't mention protocol. And again, this is, to me, a function of protocol. Now, the failure rate wasn't so large. It was only maybe 3.5%, 4% failure rate. But that's double the failure rate of the ones that of what they found with the 4 to 6 millimeter implants. So double the failure rate, to me, didn't make sense when I read this. And there was no difference between immediate and delayed implants in their systematic review. So these things clearly work. The question, again, is what's the protocol that you follow in order to get this 98% survival rate? So when you dig a little deeper into the literature historically, you can see, and this is just a fistful of them, and you look at what are they talking about? What does the literature say? And again, I'm searching for a consistent evidence-based protocol that tells me this works, and here's the reason why. When you look at the protocols, they were all over the map. You have immediates, you have flap, you have no flap, you have grafting, you have no grafting, some of them grafted the gaps around the implant if they were greater than 3 millimeters, if they were greater than 2 millimeters, if it was equal to 3 millimeters. Some grafted, some closed the gap, got closed over the socket with primary closure. Some didn't. So there was no consistent protocol, but yet if you look at the success rates, they were all pretty high. But again, there was no accepted, consistent protocol that I could isolate that was evidence-based, that could tell me, as a practitioner, tomorrow morning, what do I do to make sure I get that 98% success rate? What they all had in common were that they had open flap extractions. That was one issue in most of the older literature. But the most important thing was that they all stressed stability. Now, what does that mean? And I think Nurit touched on that before about a stable implant. What is a stable implant? Is it 25 Newton centimeters, as she suggests, in the anterior for immediate load? Is it 10 Newton centimeters? Is it 35? Is it 50? What's the literature tell us, and where is it? Is it a comfort zone that we have? Or should it be something that's based on science? So when we look at what is the science, Walker looked at this in 2011, and this was on what was considered the wide implants, the 6 millimeter implants. And they were mandibular first and second molars. There was no flap in the extractions. There was no graft and no primary closure. To put a healing abutment in, and they went back in 3 months to reverse torque. And what they found was, these numbers here are pretty important, that the initial torque value, when you had greater than 30 Newton centimeters, you had a 96% survival rate. But when you went to 15 to 30 Newton centimeters, you still had 90%. When you got down to less than 15 Newton centimeters, that means that when you twist the screwdriver with your fingers and you're putting on that healing abutment and you get the turn, that's less than 15 Newton centimeters, because most of us can't do even 15 with our hands. And yet they still had 86% survival rates. So the initial torque value that we want to be comfortable with, right? Let's look at what the literature says, and maybe we can be comfortable knowing that it's stable at less than 15 Newton centimeters. Now that doesn't mean, now stability is different, rotational stability is different than something that wobbles. If it wobbles, you can't leave it. Wobbles is not stable. But something that turns and just turns a little bit at 15 Newton centimeters, that is still, according to Walker and Morse, it's still stable enough that you can expect about 86% success rate. Now, if you think about what I first said about the type 4 bone that's available sometimes in a maxillary molar, that comes into play. So sometimes we put that implant in. Now, most of the time, if you've done enough of these, you know you crank these suckers in. And sometimes you don't. Sometimes you put it in and it's a little soft. But you can still expect a pretty high success rate based on the evidence that's out there, having nothing to do with our comfort zone. So in search of an evidence-based protocol, I started looking at this and taking pictures and looking at all the different parameters, and it occurred to me that there was really a classification system calling out. And there were just 3 different types of molar sockets that we deal with. And we published this in 2013. And you'll see that it was based on a type A, type B, and type C socket. And the type A socket is when the septum is available, the septal bone fully contains the coronal portion of the implant circumferentially within the bony housing. So putting an implant into a type A socket is not much different than putting it into a healed ridge. You're not at all concerned about the gaps or the buccal wall or the palatal wall. You're in bone completely. That's a type A socket. Now, a type B socket, and this is where things will get a little interesting. Type B socket is when you have enough bone in the septal bone to stabilize that implant, but not fully contain it. Now you bring into question these gaps that surround the implant. Because now these surfaces, either 1, 2, or 3 of those surfaces, may or may not be up against bone. Now they're up against an extraction socket. And that changes the game. Now we have to think about what's happening in those gaps, and we'll get into that in great detail. And the last in the category is the type C socket. The type C socket is when there is no septal bone. That's those conical shaped molars where you take it out and there is no septal bone or minimal septal bone, you wipe it out. Now you've got to engage the periphery of the socket. That's a type C socket. So with that system in mind, that language, now we can communicate about the socket types going forward when we determine treatment. And this is what they look like clinically. There's your type A, a couple of type Bs, maxillary and mandibular, and of course the type C. And the type C sockets mostly occur in the second molars, both maxillary and mandibular. That's where we find most of our conical-shaped molars. Right? The first molars in general are either the mandibular, the two-rooted teeth, or the three-rooted typical molars. So the type Cs mostly occur, not completely, not all the time, but mostly occur in second molars. Now there's just a few numbers that we really have to keep in mind when we think about how to treat this prosthodontically and surgically. So we talk about trunk length being about 4 millimeters in a maxillary molar and a little over 3 millimeters in a mandibular molar. And the width at its widest point in a maxillary molar is about 8 millimeters and 9 millimeters in a mandible. And the root length, that's the available bone beyond the furcation. The root lengths are about 10 in the maxilla, and also about 9 in the maxilla and about 10 in the mandible. So those are just a few numbers that seem to make that will make sense and will have everything to do with the way we treat these sockets going forward. So based on the classification and based on this few little anatomical numbers that we have, now we can start to look for treatment protocol going forward, and I'll present a little bit of research that goes along with that to sort of back up the thoughts on this. When we talk about treatment protocol, it's going to be affected by extraction type. We're going to look at the gap and discuss whether or not to graft that gap that surrounds the implant in the type B socket, maybe the type B and C socket, even the type A. Immediate provisionals. When can we immediately load, or should we immediately load? Previous infections. We'll look at, is wider actually better? And we're going to look at the consequences of narrow versus wide contours of these implants and their surrounding environment. We'll talk about some alternative treatment protocols, and again, I'll leave you with the latest data. So let's start by extraction type, looking at protocols based on extraction type. So here we have the first case of the type A socket. And what we do before we extract the tooth, no flap. Again, no flap, that's critical. And we section the tooth into its 3 component roots. And we do that usually with a flame-shaped diamond or with a long, skinny extraction diamond. You can do it with piezo instruments. And then we extract the roots gently using these exotomes that are a little bit thicker, a little beefier than a periotome, but they're really nice. I use that on every single extraction I do. And lastly, forceps that have a little narrow tip at the end so we can grab the roots once we loosen it up and it's ready to pop out. If it hasn't already popped out with the exotomes, you just grab it and sort of take it out and follow the curve, follow the path that curve wants it to take. So what we're trying to do is preserve that septal bone wherever possible. Now it's important to keep in mind what the socket will typically look like. And Jung looked at this in a CBCT study and looked at, and this is 2012, and you can see that most of the majority at first molars, you got 32% will look like this. Second molars, even more so, will look like this, where the sinus will drop down in between the roots. So it's important that we take a CBCT, because if you're expecting this and you end up with this, and these two will look the same on a two-dimensional X-ray, if you drill into this rather, thinking you've got this, you've got a surprise ready for you. So it's important that we take a scan. So here's that type A socket where we put in, this was a 5 millimeter diameter implant, and we did it at the height of septal bone, which meant at the base of the trunk of the tooth, which puts us 4 millimeters below the tissue height. I know Dr. Bittner talked about running room. All right, so running room is the room to create the profile of the root contours that come up from underneath the tissue so that we prevent having ledges in our teeth, in our crowns. So if you want a nice smooth contour, we know that you want to be 3 to 4 millimeters below the crest of tissue. Think about the trunk height. In the maxillary molar, it's about 4. In the mandible, it's about 3 1/4. 3 to 4 millimeters. So if we have septal bone as our vertical guideline, let's aim for the top of the septal bone when we do our osteotomy. That should put us in the correct vertical spot for our implant. And I started noticing in the early days of doing the immediate molars that prosthetically, my best results were on my immediates. And that was one of the reasons why, because we had the landmark there. I was looking right at the septal bone and the height of the septal bone, and if I put my implant right to that height, I was at the right vertical most of the time. Whereas on a healed ridge, sometimes it's higher, sometimes it's lower. It's a bit of a crapshoot. You lose that landmark. So it's just an easy landmark to go by if you still have it there. Now in the type A, there's no gaps adjacent to the side of that implant. So again, that's fully enclosed in bone. So what's happening out here is of little relevance as far as integration goes. As long as that bone remains intact, we have bone up against all sides of that implant. So here's what it looks like on radiograph. We put the implant in. You can see the extraction socket. And a few months later, when the final crown is delivered, you don't see any more evidence of the extraction socket walls. Now, I talked about this, the importance of a scan, and here's why. You take a look at this, and this molar is about to come out, and in 2 dimensions, it would seem that we've got plenty of room. Remember, how much is the available room on average for a maxillary molar? About 9 millimeters beyond the trunk. So if I look at this, I'm looking at that, and I say, well, you know, when I take that tooth out, my crest is going to be about here, and I should have about 9 millimeters based on averages. So maybe I take that tooth out, and I look at the socket, and I drill in. But I take that tooth out and take a scan, and look what I actually have. So on 2 dimensions, this line is probably the confluence of the cortical plates here. So that's the white line that I'm looking at, and this is the height that I'm looking at here. That's the crest. That's not the available height that I have for my implant. This is. So if I was simply to drill in here expecting this to have plenty of room, I'd be in that sinus before I knew it. And if I drill into the sinus too soon, now I've got to open it up from the side, repair the sinus wall, and do an actual lateral window sinus lift. Not my favorite thing to do, especially if I'm not planning on it. So there's evidence in the literature. Artsy actually wrote about this in 2013, and this is my case. So I took the tooth out, took the scan, saw what was there, and we did a little osteotome. Very simple, right through the septal bone, advance a little bit of bone here, and I think it's not projecting all that well, but you can see the dome of bone here. That was probably a cadaver bone, so it didn't show up. I typically use a xenograph, so you really see it, but you can use either one. So this tends to stay where you put it a little better. So you do your osteotome, place your implant in the type A socket, so it's still surrounded by bone, and that thing locks in. So now it's a type A socket with an osteotome above it, and there you can see the implant at the time of placement. Now what's happening here? So forget that there's a screw in the middle of it. You take out a tooth. It's an extraction socket. It's important that we think about the biology of the extraction socket and what relevance it has to our implant placement in a type A socket, in a type B socket, and then in a type C socket. So we have to sort of dial back and think about freshman year in dental school where we all learned it, and sophomore year where we all forgot it. Amler wrote about this in the 60s, and the key things here to remember is that we're healing. An extraction socket is healing from the periphery. Where does the new bone come from? Because if you leave it alone, what happens? It fills with bone. Right? It fills with bone. There are plenty of authors who showed if we stuff a graft material in there, it delays the socket healing, and you even get, on average, less vital bone in your socket than you would if you just left it alone. The reason we tend to graft, and we'll talk about that as to whether or not we should, the reason that the industry has us graft and that we tend to graft is to preserve the aesthetic contours. But in terms of bone fill of the socket, we don't need anything but a blood clot. And here's why. So the clot forms and it's gone by the 7th day. But what's happening during that first week? And that's the critical time here. The first 2 to 3 days, you've got granulation tissue at the periphery. So little blood vessels are starting to come in from the peripheral walls. That's happening immediately. Epithelium doesn't cross that fibrin clot. Doesn't go over the clot. The clot has to resorb for the epithelium to start creeping. As the clot is starting to resorb at the top of that socket, then the epithelium starts to go to about a ½ millimeter to 1 millimeter per day. It's like if you had a scab on your arm. The skin doesn't grow over the scab, it grows under it. And eventually, you know, that last little bit, you pull it off and it hurts, and what happens? It bleeds. It bleeds because there's new blood vessels that are underneath there. That's why your skin grew across it, right? So the vascularity is what allows that to happen. By the 7th day, you've got osteoid at the base. So you've got bone cells already. But at the end of the first week, at the top of the clot, at the top of the socket, you got a biological Band-Aid. You got the clot. So you got your Band-Aid at the top. You got bone coming in from the bottom, blood vessels coming in all from the sides and the bottom. What's happening at the top to the epithelium? Nothing until the clot is gone. So now you need the blood vessels to work their way in. Then the epithelium comes across. After about a month, a little over a month, 2/3 of the socket is filled with young bone at about 5 weeks, which is why we know that about 6 weeks tends to be a good time to put an implant in the so-called delayed immediate or delayed placement. And at 100 days out, you don't see any evidence on radiograph of the socket. There's been bone turnover. So this is not rocket science, and it's just a few little things that we have to keep in mind when we decide, do we put the implant in, do we put a graft in, do we lay a flap, do we put a membrane, do we not put a membrane? This is what we have to think about. This is what determines what we do in that socket. Very simple. So let's go back to a type A socket. Now we've got clinical, some photographs at 1 week. There's the fibrin clot. Doesn't look so pretty, but to me, biologically, that's beautiful. That's the Band-Aid. And notice where the epithelium is. That's 1 week. It's not at the side of the implant yet, right? It's still out here. It's waiting for that clot to start resorbing. At 5 weeks, now we've got immature soft tissue, and that contour, then it'll start to fill in, and the contours will improve. It'll flatten out. It'll get pink. It'll look just like all the surrounding tissue. And 3.5 years later, that's what our healthy implant sulcus looks like. And we've had a little bit of ridge remodeling. If you look carefully, that's not the same contour, but up against the implant, we've got bone, we've got healthy soft tissue with a scallop. And if you look on radiograph, we can see bone held pretty nicely 3.5 years later, and that's the soft tissue profile around a 6 millimeter diameter implant. Now we'll move on to the type B socket. This is very different than a type A socket. Why? This is the critical element here. Now we've got a stable implant at the height of the septal bone, so vertically it's good. But now we've got gaps in contact with the implant. What's happening in the socket? Amler just told us. So now think about, what are the implications on this implant? Will that soft tissue get to the side of the implant, or will bone get to the side of the implant? And that's what we have to really come to grips with. And that's where we're going to decide, should we stuff graft material in there? Or is that going to create a barrier? Do we need a membrane? Do we need to lay a flap? What do we do to keep the soft tissue away, or is the clot enough? So what about those gaps? Dennis looked at this with two of my partners, Tarnow and Chu looked at this in a patient in 2011. They wanted to see what was happening because we were doing these things. And Dennis and I first published on this gap when we did 2 mandibular incisor implants to support four teeth. And consistently, we were seeing these big gaps that we were leaving because we would place our implants lingually for a screw-retained prosthesis. And if you look at that article, it was in the compendium, I think it was 2009, and you saw consistently we had these gaps. And it didn't seem to matter. And then we moved on to other teeth, and we had gaps, and it didn't seem to matter. So the theory was, this based on Amler's work, that the clot was preventing the soft tissue from coming in. So what they did was Dennis wanted to core out an implant in a human and see if, and get something that proved, that was proof of principle. So they put this extra implant in. It was a full arch of implants. This was the last tooth to come out in a serial extraction case. They didn't need another implant to support the bridge. So this was sort of an extra implant, and the patient agreed to let them take it out afterwards with a little trephine of bone around it. So if you look at the healing that went on here, you can see the ridge remodeled. It's not as big, but look at that gap. That's a 4 millimeter gap at least. And they didn't do anything with it. There's pretty healing abutment on. Let it heal. No graft, no nothing, just a clot. And let the whole thing heal. And then they cored it out. And on radiograph, this is what it looked like on a CBCT, and histologically, you saw bone to the first thread, just as you would in a delayed protocol. So if you look at the animation here, you see it's starting to move slowly, and you can see the clot is there, but that soft tissue doesn't get to the implant until the vascularization is completed. Now it's at the side of the implant, but by then, you've already got bone filling in the base of the socket. So again, the epithelium cannot cross the blood clot at the top of the socket before new blood vessels and connective tissue are formed and replace the clot from below. And that's a critical thing to remember, and that's why these things seem to work. That's why they do work. So this is proof of principle, if you will. So the bone will form on the implant instead of having a long epithelial connective tissue at the attachment. Now this goes against what we thought before, because the literature, and if you think back to Becker-Nakamoto's study where they created with a trephine a socket in a dog study, and they created a wider and wider socket. But and then they put an implant in, and then they went back and they looked at where the first bone to implant contact was relative to the width of that gap. And they noticed the critical gap distance that appeared in other articles in the literature. That was about 2 millimeters. So if you had 2 millimeters between the socket wall and your implant, you started to have soft tissue ingrowth. Why isn't it happening here? Because all of those early studies, and Wilson's study on humans even, they all laid flaps. They all laid full thickness flaps. Now if you lay a full thickness flap and you don't have that clot as a barrier, now you pull that tissue right up over the top and suture it. Now that tissue with its own blood supply, it's not waiting for the blood supply from the clot anymore. You're bringing it up in a full thickness flap with its blood supply, putting it right over the gap. Now it's going to go down along the side of the implant. And that's what was in the old literature. That was why the critical gap distance was 2 millimeters. If you sutured over an implant with a gap of 1.5 millimeters to 2 millimeters, you got soft tissue ingrowth. So this sort of didn't feel right to us when we were doing it because that was the literature that was available. But on a no-flap extraction with a blood clot as the barrier, it's very different. That was the essence of it. So do we graft the gap? Well, no, not for osseointegration, clearly, because the bone will get to the side of the implant. Now, it's optional. It's not wrong to put a graft in the gap. And what that can do for us, and Fugazato, Block said it, that there are, for aesthetic contours in both type A and B sockets, you know, some smiles show the first, second molars. Some smiles show the third molars. And that may be important to your patient. And if I were to take out this patient's first molar and create a big valley there, right, with a sunken in valley in the tissue, even though I've got a successful implant, that might be an aesthetic failure. So in a type A socket that looks like that, I might graft those buccal gaps just to preserve some ridge contour. But in terms of integration of the implant, I don't need it. In a type A and a type B, don't need it for a successful implant. But maybe just to fill the contours, plump it out, that's fine. So now we go back to that type B socket with the gaps, and we look at it 1 week later, and you can see the fibrin clot. 2 weeks later, tissue is still being kept away. Radiographically, it heals. There's the gap pre-op, and then you can see no gap in the bone, and it just healed with no graft, no membranes, just a blood clot. Now what about alternative procedures? Well, you could put it in a socket, in a root socket. We call that a type BR, because you're still engaging the septum, a portion of the septum here, so it's technically a type B socket, and the little r means I'm in a root space. So you could do that, and sometimes you get away with it. There's your palatal root. It's a nice big socket most of the time. And sometimes you get away with it, and the contours can be okay, but look carefully at this little depression up here, because the implant is palatal, and what's going to happen on the buccal, that whole thing is going to shrink in. So maybe I graft the 2 buccal sockets here, but you know, it's got other issues. So Jung also talked about this, and he said that 97% of first molars, 73% of second molars, this is what you actually have. So your palatal root, is here, and if you put your implant in at that angle, and you have this kind of resorption that goes on, you can see the issues that you have in terms of your crown contours. You're going to create either a ridge lap or a very narrow crown, let alone the depression in the ridge that occurs if you don't graft that gap. And if you graft that buccal root and try to preserve this, then what does your crown look like? So then it comes straight out here, and you've got a huge ledge off the buccal side of your crown. How do you clean that? So placing in the palatal root is not necessarily a great answer. In the last tooth in the mouth, second molar, if it's the terminal tooth, it's the first molar, and there is no second molar, you can sort of get away with those a little more easily because it's more cleansable. They can wrap floss around it and sort of get to it more easily. But when it's the first molar with another tooth behind it, I would think twice about the palatal root engagement. Now we look at this type C socket. And I said the type Cs mostly occur in second molars, both in the mandible and the maxilla. And this is a vertical fracture on an endodontically treated tooth. We already had an implant in the first molar. Now this tooth has to go. We take out the tooth, and it's a type C socket. And what occurs to me when I look at this type C socket is, what does that look like? It's not an oval. It's really a figure 8, isn't it? But when we conjure up a type C socket, and when we read the literature about these sockets, it's really considered like an oval or a square. It's not. It's a figure 8, and you'll see why that comes into play. So let's go back to the numbers. What's the available root length on average for a mandibular molar? Well, it's about 13.5 millimeters in total, minus the trunk. You got about 10 millimeters left of root in general of available bone if you're not going past the apices. So if you're close to the nerve, you've got about 10 millimeters safely on average to deal with. You got a root width at its widest, which is the buccolingual dimension, of about 9 millimeters. So this is about a 9 by 9 space that we have with a 10 millimeter depth. So that requires a wide diameter implant in order to engage it. So, and here's where I say there's nothing else on the market that I know of that can do this. What else can engage an 8 millimeter wide hole? So we need something that's going to go out wide, 7, 8, 9 millimeters. So that's where these wide implants come into play. And this is schematically, this is a picture from their catalog, and you can see this is the 7, 8, and 9 millimeter diameter implants. And what I love here is that at its widest, the 9 millimeter actually gives me a 7.5 millimeter prosthetic platform. And in a few minutes, I hope to show you why that, to me, that right there is a game changer. That 7.5 millimeter number is gold. And this is the kit that you use to put it in. Typically, we start here, and then we start the shaping. If you're in a type B, A or B socket, and you're going to widen it out, then you'll use this. In a type C socket, we generally just go right to one of these burrs, the shaping burr. And then if it's hard bone, I've learned that we have to, tapping is very important in very dense bone, type 1, type 2 bone. I'll tap those because these things lock in. And you don't want to be almost there, because that's it. Sometimes you can't even back them out. You want to make sure that you're going to get it to the full extent that you want it, which is 3 to 4 millimeters below the tissue surface, which brings you subcrestal. Subcrestal. And that's going to be important when you start to see the literature on what's happening at that bone around the side of the implant. So Vanderway looked at this, and they looked at implants between 8 and 10 millimeters. The 10 is not available. They go 7 to 9, but they looked at all of these. And essentially, they showed a 96% survival rate, irrespective of loading or surgical protocol. That sort of agrees with all the literature that we've seen so far. It's all high percentage. But when you dig into that literature, what you don't see, all the cases they threw out that they didn't use because they didn't have a protocol, and they didn't use all the available sites to them. So I mentioned just a second ago about the buccal plate. Now, I know when I speak about this stuff and when I started doing it, I started off today saying this is different than in the anterior. Right? In the anterior, you saw the Team Atlanta, you saw Nurit talk about we stay away from the buccal plate, right? Peter Worley, when he first did his article on, the seminal article on immediates, it was right up against the buccal plate. We soon found out that that's not where you want to be. That buccal plate resorbs, you got an implant showing in the smile. So we go palatal to it. We do the dual zone grafting. We try to do everything we can to preserve that buccal plate. We don't go up against the buccal plate. Why? Because the titanium screw is not going to do anything to support it. There's no blood supply there. It's all about blood supply. That buccal plate is paper thin half the time, most of the time, and you're going to lose it. So we stay away from it. Again, it's very different in the molar. So if we're engaging the buccal plate, what's our concern? Should we be concerned? This is not an anterior tooth. So should we be concerned about engaging the buccal walls? Will that implant actually preserve the socket wall? So if you put a screw up against bone, does it support the bone? No, because it's not supporting it biologically, and we know that from Araujo's group. And they looked at an extracted tooth with a thin buccal plate. You took that out, put an implant in, the buccal plate resorbs. Whether you put an implant there or a graft there or nothing there, that buccal plate is going to resorb because it's a matter of disrupting blood supply. That thin buccal plate is supplied by the buccal flap, by the PDL, and by the marrow space. There's virtually no marrow space in here. It's a thin buccal plate. There's not much blood supply coming from inside. If you lay a flap, you disrupt the buccal plate's blood supply from the outside, which is why we don't lay a flap. And when you take the tooth out, by definition, you're removing the blood supply from the periodontal ligament. So that's going to resorb no matter what you put in its place. A titanium screw, particles, anything you put in there is not going to affect biologically what's happening to that bone. We don't have the technology to reverse engineer that and save it. So should we be concerned about remodeling, and if so, what should we do? Well, first of all, again, the flapless extraction is key, and we count on this bone being thicker than it is in the anteriors. How do we know that? We look at what the article, the literature tells us, and we look at dimensional changes of extraction sockets, and this is with full thickness flaps. And Nurit mentioned this earlier, and here's the numbers. Here's the articles. 4.5 millimeters of buccolingual change. Vertical changes up to 2 millimeters, 1.5 millimeters. These are some pretty big numbers of the buccolingual changes, up to 4.5 millimeters, 6 millimeters. That's when you laid a full thickness flap and disrupted the blood supply. Without a flap, look what the numbers are. That same buccolingual dimensional changes, now you're talking about maybe 1.3 millimeters at its widest, down to about 0.5 millimeter. It's a different ballgame if you don't lay a flap. And that's anteriorly with thin buccal plates. Posteriorly, what do the buccal plates even look like? Well, this article by Kaylee looked at this, and I know this is just from their article, but I want you to look at these two. They looked at 1 millimeter, 3 millimeters, and 5 millimeters up from the crest. Now, the important aspects of the 3 and 5 millimeters up from the crest and the thickness in the first and second molars, look at this. They define thick as greater than 1 millimeter. And if you don't lay a flap and you can expect less than 1 millimeter of resorption, and you've got a buccal plate that's greater than 1 millimeter, that's thick. So if you don't lay a flap and you've got a thick buccal plate, in 80% of the cases, over 80% here, almost 90% here, you're doing pretty well in your maxillary second molars, which is where your type C sockets are. And in the type C sockets in the maxilla, that was mandible, sorry, in the maxilla, same thing, at the 3 and 5 millimeter heights, you're thick over 70% of the time in both the first and second molars. So you can pretty much count on a thick buccal plate. This is borne out by Katranji's group with Mish and Wang, Hamli Wang. On average, your maxillary buccal plate is 2.23 millimeters. Again, relate that to the literature of what we can expect in terms of change if we don't lay a flap. So you'll lose a tiny portion of this, maybe 1 millimeter if at most, usually about 0.5 millimeter. So if you lose 0.5 millimeter of your 2.23 or of your 2, you still have plenty of bone up against the side of the implant. Now, what was interesting to me is that all these articles, and there were some others that measured cadaver studies and radiographic studies, and they all separate their measurements into mesial and distal at the side of a molar. So they're measuring here at the root surface. That's not where we're engaging the plate. And it's already thick there. They're telling me that this is already a thick buccal plate, don't worry. That's not where I'm engaging a type C socket, is it? Remember I said it's a figure 8. So what's actually happening, we're engaging there. There's that chunk of bone that pinches in, right, to create the figure 8 that ran down the grooves of that tooth where the two roots were fused. So you're really engaging across this and not even on those outer walls. So this chunk of bone, which if you measure is usually at least 2.5 millimeters, if not more, where's that going? If you don't disrupt the blood supply with the buccal flap, Where's it going? It may remodel from the outside, and it will. That's not going to look exactly the same later on. But am I going to lose that whole chunk of bone? I don't think so. There's no precedence for it in the literature that tells me I should lose it if I don't break it in my extraction and if I don't lay a flap. If I leave it intact, if I don't flap it, it should be there to support that implant and keep the soft tissues exactly where they are for many years. For good, I hope. So this is what it looks like. We engage the implant in that figure 8. Not on the thinner portion of the buccal walls. So here's what we have in a Type C socket. Now we've got gaps to think about. And we know what the gaps mean to us because we just examined that. So if we leave this with just a blood clot, and we're engaging this nice thick piece of bone here, and the wall is intact here, we should have a pretty, fairly predictable success. So here's some clinical examples. Here's a Type C socket where we extracted this lower second molar that was vertically fractured, put it 3 to 4 millimeters from the tissue crest because now I don't have a septum, right? The interseptal bone is my landmark for my vertical. So I look at the soft tissue. I need to get 3, 4 millimeters down so I get running room. Now the wider the platform, the less important the vertical depth is because I get to that wide surface, that wide contour, much quicker off of a 6 or a 7 millimeter platform than I would off of a 4 or a 5 millimeter platform, right? So you don't need the same depth on a big fat implant that you do for a narrow implant. If I want to put a standard diameter implant in a molar socket, I better go deep, otherwise I'm going to have that mushroom look. So here it is 1 week later, and now that gap is pretty much closed because the clot is basically now gone, but it was a tiny little gap. So I'm not worried about that soft tissue getting there because I know that that gap was minimal. It was less than a millimeter on either side. And here's what it looks like clinically. 3 years later, this is one of the older style implants, so we had the abutment, but you see 3 years later, the socket is there. And like I said, you get remodeling of the ridge. So that's not the same ridge that we started with on the buccal. And there you can see the contour of the crown and the embrasure space, the nice natural embrasure space that we have. And on radiograph, you can see it held the bone. So it's held the bone, it's held the soft tissue, and on a scan, you can see the bone is still up at the top. So it works. So now how about immediate provisionals? If these things lock in so tight, can we immediately put a provisional on them? Well, what would that provisional do for us? It will maintain the soft tissue architecture. It will prevent food impaction, which is typically a problem here. And I tell patients when we do this, listen, eat on the other side, stay away from things with seeds, little kernels, no rice for the first week. I just don't want stuff getting stuck down inside that socket. It doesn't seem to be an issue. Patients pretty much stay away from it. And if the clot is not disrupted by a toothbrush or a piece of chicken, it stays stable and nothing will get down on the inside of that. So that clot is stable by the time they've left your chair most often. But it can help stabilize the clot if you occlude the top of that with a provisional restoration of some sort. And this one was done by my partner. I placed this implant, and John Zamzak made this provisional restoration out of occlusion. So it's not immediately loaded. And of course, if they forget and they eat a bagel on that side, it's immediately loaded. But you have to trust that they're going to stay off of that. And I tell my patients if it's harder than mashed potatoes, it doesn't go near this implant, whether it's a molar or any immediate implant. And if we don't put if we feel that it's not strong enough or that it's not important enough to take the risk of a full-on provisional, we can do one of these customized healing abutments like Dr. Bittner showed you. And here I got a little carried away, but I want to have a marking as I'm manipulating this, taking it in and out and contouring it. I want to know the buccal aspect. So I marked it here with a racing stripe. You can put a dimple, you can put anything you want. And now it's pretty easy to form this. So we put put a temporary cylinder on, and then with powder and liquid, with a fast-setting acrylic, we just paint it right at these margins, pick up the surrounding margins, unscrew it. I mark my margins with a little fine red pencil, and then fill in from below, polish it, and put it back in. And here's what happens. Because of that, we've maintained the soft tissue. Now I can take an accurate representation of the soft tissue in my master model. We unscrew the provisional. You can see what we've got there in terms of soft tissue profile. And you recognize we have remodeling, but we have bone up against the side of the implants, don't we? And that's the final crown. And here's another one where you can really see it supporting the soft tissue. And there's just a little dimple on the side, which is pretty much what I do now. I don't put the red stripes in them. But a little dimple on the side is enough to just tell you where the buccal aspect is. You can make it shorter, longer, doesn't really matter as long as it's comfortable to the patient. Highly polished and steamed on the internal aspect. Now, very often you take out these teeth and you've got previous infections. What about previous infections, and how does that relate to what we do? Well, if we look at what the literature tells us, and here you can see one where we placed it in, we occluded this. If you can just obliterate that socket, Wadsdorf showed us that as long as you can completely debride the socket with thorough debridement, that there's no difference in success rates between infected and non-infected sockets. Now, if there's no buccal plate, you don't want to put your implant in, because now you've got soft tissue up against the side of your implant. Bone is not going to come from soft tissue. So this is a no-go zone for me. I got no buccal plate or no palatal, no bone on one of the outer walls. I don't put the implant in. Now, is wider always better? And what are the consequences here? So with wide implants, you can see that we've really got a nicely defined, more natural-looking embrasure space. Clinically, what's the relevance? Well, a few years back, I started to notice in my own office that I was seeing a lot more decay in the posteriors next to molar implants. And it was troubling to me. And I asked around if people were seeing it, and I was getting shade. Nobody was agreeing. But I'm looking, and I see this. And I see decay, 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 everywhere I looked. And I wasn't seeing that anteriorly, and it was weird kind of decay. Decay that would just blow out teeth like this, and like this, whether or not there was restorations, and I couldn't just accept that. So I'm trying to figure out what it is. So I took on this research project, and together with two of my former students, Samantha Rorden and Victor Kagan, and they helped me measure. We did a radiographic retrospective study. We looked at 306 molar implants adjacent to natural teeth. So there had to be a tooth on either one side or both sides of the molar implant. And that yielded 424 sites, either mesial and distal or both. And it was a radiographic analysis. We had calibrated digital radiographs. And we looked at all sorts of variables. But the variables that spun out and became useful to us were the horizontal distance from the platform abutment connection to the adjacent tooth, and we'll call that ITD, the implant tooth distance, the vertical distance from the platform to the contact, and whether or not, at least on the radiograph, we could determine if there was an obvious open contact. And if you look at radiographs, you really can't determine the status of a contact. But we looked at it and said, if it's wide open, it's open. So that's not really relevant to this. Schematically, what this looks like, here's our measurement. We dropped the vertical line and went across from where the implant abutment and platform met to the adjacent tooth. We call that the ITD, the implant tooth distance. And there were two possible sites, mesial and distal. And statistically, this is brand new data that just came about last week. And I want to thank John Gerbic from Columbia University, who's the statistician who stayed up late at night to get this done so I could bring it to you. And what we found was that of the 424 sites, 69 of them decayed. Of the 306 implants, 22.5% of the molar implants we put in were associated with decay on the tooth next to it. That's a problem. If we're doing something that's associated with maybe causing a problem almost a quarter of the time that we do it, maybe we have to do something different. And that's what the numbers are telling me here. And 16.3%, if you break it out into mesial and distal, even that way, you still get a pretty high number, had sites. The time frame was not really relevant because this is a retrospective study. Some of these patients were just surgical patients that may not have come back for years and years later until they got their next implant, so we didn't follow every one of them. So we need a prospective study to get a better time frame. But visually, on a graph, this really lays it out for us. The number here is the N value, how many of each showed these characteristics. If you were less than 2 millimeters, only 8.6% of the cases showed decay. As you got up wider and wider, further and further from the tooth, when you got to the 4 millimeters, look at this, over 22% decayed, 27%, 35%. And that's not a small N. That's 31 out of the 300. That's 10% of the implants were going to decay 36% of the time. It's too high. We're doing something wrong. We're not paying attention to the right thing if these numbers are right. And statistically, the numbers appear to be right. We had a p-value of less than 0.0032. That's really powerful stuff. And the odds ratio of that, if you were 4 to 4.9 millimeters, you are 2.5 times more likely to see decay. You get up to 6 millimeters, you're 4 times as likely to create decay on the tooth adjacent. I'll come to you with questions in a minute. I got the red light up here. So I look at this X-ray, and I see this. And I see on one side, I'm up against the tooth, I got no decay. On this side, I've got a bigger distance, and I've got decay. It's a little bit of a red light. It's not going to happen all the time. So why doesn't it happen all the time? Well, some patients, we don't know all the answers. So what I'm showing you here is a pattern. And it's related statistically significantly to the horizontal distance. Can I tell you exactly why? No, but I can theorize. And I can theorize based on my own experience, which is I broke a tooth, a first molar. I bit down and cracked a molar. And my partner put in, this is a bunch of years ago, when a 5 millimeter diameter implant was a wide implant. So I got a 5 millimeter implant in my first molar. And if I don't take the floss and go up and wrap and slide all the way up those contours routinely, I get a little soreness. I get that perio soreness that we hear from our patients. And it started me thinking about it. And I started asking my patients, show me how you floss. Show me how you floss your implant. There wasn't one patient, no matter how many times we told them, there wasn't one patient that goes up, wraps, slides, and comes back down. They floss it like they floss all their teeth. They go in and out, if they even floss. Most of them aren't flossing anyway. So is it hygiene? Is it the contours? We're not really sure, but it is related to the gap between the implant and the adjacent tooth. That much I can tell you statistically with certainty. So should we always go wider? It would stand to reason that given this, we should always go wider, right, to get closer to the tooth. But what are the consequences of going wider? What's the problem with that? Well, if you go wider, now you bring those gaps into play in a type A socket, so you better know what to do about the gaps. And if you don't have an outer wall, now you've got a choice to make. I went wider to try to prevent decay. Now I'm into a gap, but I don't have an outer wall. Did I do the patient harm? Did I do good? So it sets up a whole nother set of questions for us. If you eliminate the septal bone by going out as wide as you can, sometimes it makes it more difficult to stabilize the implant. You had all that nice bone there that was easy to stabilize in. Now you want to go wider because I just told you you should, and now you got an implant that's hard to stabilize. So sometimes that comes into play. What if the ridge is too narrow to go really wide, especially in a healed ridge? You don't have a big wide ridge. If you came back to this tooth, or a tooth has been a long-standing tooth, you know what happens to that ridge. It narrows down. So mesial distally, you might have your 12 or 14 millimeters between roots, but you may only have 6 or 7 in buccolingual diameter. So what do? So here's a case where I've got 14 millimeters from root to root under an old 3-unit bridge, and the patient says, I don't like my bridge anymore. I want to, now that we're going to replace it because he decayed, I want an implant. So I measure that. What's going to happen in that ridge that's already too narrow for anything wider than a 5 millimeter diameter implant? Do the math. I got 14.5 millimeters, subtract 5. That leaves me 9.5 millimeters of space divided by 2. That's almost 5 millimeters on either side. Statistically, I'm up around 30% chance of getting decay on one of those teeth. I probably shouldn't do it. Or at least I better tell the patient that this is coming down the pipe for you. If I'm in Vegas and I'm playing the odds, I think, I'm going to bet that you're going to get decay there on a high percentage of your cases. Are they playing me off here? That's never happened. Wow. Am I off? Am I getting the hook? I got 2 minutes. Wow. All right. Let me just finish up. Can I finish? I'm almost done. Wow. That's a first. I'm from New York. And I'm known for speaking like lightning fast, so I'll go fast. All right, because this is the good stuff. I'm sorry. So you got one. So what do? I want to put 2 millimeters in, 2 implants in. Now if I do the math, now I can get closer to the teeth on either side. I don't really care what's happening between the 2 implants, do I? Because those 2 implants are not going to decay. So I want to get closer. If I've got a ridge that's already too narrow and I got 12 millimeters and I want to get a 6 in there, right? I got to anticipate grafting. So here I am, and it changes my thought pattern. I'm not going to stop with a narrow implant. I'm going to say to the patient, I got to get to 6. I know I'm going to graft, so I'm going to anticipate the graft. No surprise. I open it up, I graft, and I put my wide diameter implant in. So, and lastly, I'm taking out this second molar, and the second bicuspid, first molar, second bicuspid. Typically, you would put the implant down the center. Every article out there, including Herzler's article about drilling through the tooth, you want to get down the center of the implant, of the tooth, don't you? I don't think so. So now I'll go towards the distal. I'll put it in the distal root here, not go down the center, stay away from the buccal plate, which is already compromised, get closer to that root, get to within 2 or 3 millimeters here, leave a bigger space between the two. That's a difference in protocol for me. I no longer go down the center. And last, there's an old school solution. If this tooth is failing, maybe don't take out the whole tooth, do a hemisection, bring back what we used to do 25 years ago routinely. These things work. This is now 2018, it's 15 years later and it's still hanging in there. We've got another one with a hemisected tooth. I'm running out of time. Latest data. All right, latest data, last one. We just submitted this, 300 implants. It's a survival study. We looked at 300 implants, 33 of them were immediately loaded, broke it down into the extraction types, 97% success rate. And again, we did this because we had an evidence-based protocol. So as opposed to the old literature that was sort of pie in the sky, a crapshoot as to how you did it, now we have a protocol of how to do it based on all this stuff that I just presented. And in conclusion, I'll skip this and get to this. So in a type A socket, go ahead and place it regardless of the outer walls unless you need to go beyond the septum. In a type B or C socket, place it if the outer walls are intact. I like to say go wide or go 2. Right? It's like go big or go home. Go wide or go 2. Get as close to the tooth as possible. Immediate provisional is a fine non-loaded crown or a custom healing abutment as long as you have initial stability. And you got to stress home care and fluoride. Not every patient can pay for a graft or 2 implants. So if you're going to compromise with a narrow implant, play the odds, put them on fluoride, pretend they're a decay-prone patient, and go from there. And with that, I can say thank you.